Good afternoon, everyone. Thank you for joining us for our PA Health Talk program. Today, we are pleased to bring you a presentation about spine treatment options. If you have a question during the program, please feel free to put them into the Q&A, and we will get to as many as we can at the end of our program. And at this time, I would like to introduce our speaker, Dr. Russell Strom. Dr. Strom is a fellowship-trained spine surgeon with Geisinger Neurosurgery. And with that, I will hand it over to you, Dr. Strom, to begin our program.
Thank you, Jessica. Good afternoon, everyone. My name is Dr. Strom. I'm a spinal neurosurgeon, and I would like to give you some, I think, key information to inform you about how you can help your neck and back. You know, back and neck pain are very common. Among the most common reasons people see a doctor and suffer, 80% of people experience neck and back pain at some point, and these episodes can improve spontaneously, but they can also recur. And so the symptoms when it comes to neck and back pain can broadly be separated into axial pain and neurologic pain. And so axial pain is from the intrinsic wear and tear of the spine, discs, joints, muscles, ligaments that get wear and tear over time. And one generally feels axial pain in the middle of the spine. Sometimes it can be what we call referred or felt in the paraspinal region, meaning in the back, but on one or both sides. On the other hand, neurologic symptoms occur when you get radiation of pain, radiating nerve pain, sometimes numbness and weakness down in extremity, frequently from mass effect or basically buildup of the arthritic changes that then start to pinch a nerve. So when it comes to initial evaluation, there's many possible causes of neck and back pain, and we want to, when we evaluate a patient, to know to further define the nature of their symptoms, to know what is the best next treatment. And there's a varied pathway depending on whether there are urgent symptoms or more routine symptoms. And so we want to do is localize and characterize the problem, identify what are called red flags, which are things that are worrisome for something urgent. We also want to identify risk factors. It turns out that there are common risk factors that many folks are unaware of things that can actually cause disc disease and things that you can change, modify to lower the risk of more wear and tear. And most of the time for back and neck problems, the first line treatment is non-surgical. Only about 1 in 10 people with neck and back problems end up needing to have an operation. And so an important part of that first evaluation is to determine the timing and the need for imaging and a surgical evaluation. And so the pathologies here are varied, but by far the most common is degenerative disc disease, wear and tear of the discs. Adults can also get scoliosis and other deformities. Children get scoliosis, more congenital reasons. Adults, it's more of a bad case of the wear and tear. There are, however, rare causes, and that's why we want to look at the red flag symptoms of trauma, infection, tumor, or even vascular problems. And so what are these red flags that justify kind of urgent imaging and urgent evaluation? So they're either neurologic or non-neurologic. And the neurologic ones essentially are severe and acute weakness, not just a partial weakness, but an inability to move an extremity against gravity. So a mild weakness, a heaviness sensation doesn't really classify as an emergency, but an acute or profound weakness does, and also complete loss of bladder and bowel control. Not urgency like running to the bathroom, but lack of ability to control. Those things are urgent and merit either going to the emergency room or having your primary care doctor order you what we call a STAT or an emergency MRI. Other things that can be a sign of an emergency are if you have a trauma. If you have a new pain after a major injury as a younger person, or even a minor, relatively small fall as an older patient because of osteoporosis or other skeletal conditions, you should get treated and evaluated sooner rather than later with imaging. Tumor, if you have a history of cancer or unexpected weight loss, you need an MRI before any type of non-surgical treatment. Infection, history of fevers that correlate with your onset of pain, or drug use, intravenous in particular, recent infections, or if you're immunocompromised from poorly controlled diabetes or a rheumatologic disease, you want to consider early imaging. So in the absence of red flags, so that's basically 95% plus cases of neck and back pain do not have these red flags. The initial management is non-operative, and that consists of physical therapy. And physical therapy can be initiated by any provider, whether it be a physician or a nurse practitioner or a PA. And you want to do physical therapy for about 4 to 6 weeks. It can take time for it to work. because what we're doing with physical therapy is to try to build up the core muscles that support the spine in hopes that the spine can heal naturally. And it often does. In fact, it more common than not does. The discs, that when they herniate, they have the potential to regress, to pull themselves back in. Arthritis, like any kind of inflammatory thing, can exacerbate and then get better. And even a pulled muscle, of course, can heal. And that includes nerve pain too. Sciatic pain down the leg has a high chance of spontaneously healing, unless there's, again, one of those red flag symptoms. If you just wait it out, do some physical therapy for about 4 to 6 weeks. And so because surgery is invasive and because it's not always essential to heal, you want to start off with the less invasive and then go to the more invasive. And disc disease, of course, isn't curable either. There is no cure for the wear and tear of the spine. We can tackle problems as they come, however. So there's not an emergency if you don't have a red flag, and so you want to start with the basics. So physical therapy improves the mechanics of your spine, essentially directing the center of gravity backward, or offloading those painful discs and joints, and promotes the natural healing of the problem. It works over half the time. And it's important to be really healthy in your mindset. It will not feel better right away. In fact, frequently folks have more pain after PT for a week or two, and then week 4, week 6 come in and they feel better. So be patient. Other things that can be done for acute pain are medications. Now, you want to stay from opioids. Very rarely are they effective for either acute or chronic pain. If you have to, they're sort of a last line treatment, but things like corticosteroids or different kinds of nerve medications that don't have as much of a sedative or addictive potential are really effective for nerve pain. And then anti-inflammatories and muscle relaxants are good for back pain. So then now 4 to 6 weeks go by, and with the help of your physical therapist and your primary care doctor, you're no better. Then what do you do? Well, that would then prompt a need for an MRI and seeing a spine surgeon. If conservative care fails, you need to see a specialist. And the primary doctor can order both of these. It's important to know that as surgeons, we rely upon imaging to make a diagnosis. And so we're essentially as blind without an MRI as a cardiologist is without an EKG. If a patient has chest pain and sees a heart specialist without an EKG or testing, that cardiologist really doesn't have much insight into their condition. So you can get both done at the same time, a referral for an MRI and a referral for a spine surgeon. There's also the option of interventional pain, which is a kind of an intermediate step between the physical therapy and the surgery. This is sort of a way of trying to help some of the inflammation over the discs and the joints. And for some cases, that aren't really severe enough to need surgery, but maybe aren't responding well enough for PT, that kind of intermediate case of neck and back pain can oftentimes be effectively treated with these injections. It's also good for wear and tear arthritic changes that really don't have a surgical fix because it provides some anti-inflammatory effect. However, injections are not effective usually for severe nerve compression or malalignment, like, for example, scoliosis or some major deformity or instability of the spine. In general, for those cases, surgery is needed. Now, who does injections? A surgeon doesn't do injections. It's actually a pain management physician, and they can be a source of referral too. Your primary doctor can refer you to pain management if you like to explore the option of injections. And they can do an assortment of injections, one kind for nerve pain, one kind for joint pain, another for muscle pain. There's also important to know with chronic pain that this is very commonly coupled with suffering, and understandably so. There are some cognitive strategies that help kind of pull your sort of your conscious state, your presence away from the pain, because pain and suffering are related, but they're not necessarily the same thing. There are cognitive exercises that a psychologist can teach patients who are suffering from chronic pain to sort of to kind of distract themselves and change their state so they're not necessarily in pain. They're not pain free, but they don't live necessarily in that pain state. And for some cases of neck and back pain, these pain psychology exercises are more effective than surgery. Others require surgery. Everything is different. When it comes to imaging, an X-ray is not a great first-line test because it doesn't really show the details that are needed. We do use X-rays in a surgical clinic to look for malalignment, but it doesn't substitute for an MRI. An MRI is the gold standard. CAT scan is a good test for trauma. If you have a bad accident, you should go to the ER and get a CAT scan to rule out a fracture. But it doesn't really show much else because it doesn't have the resolution for soft tissue. And soft tissue includes things like nerves and discs. Those are the things that we want to look at. If you can't have an MRI, there is the option of getting what's called a myelogram, which is a pretty good substitute where they put a needle in the back and they inject some dye. And that kind of helps distinguish the nerves from the bones in a way that an MRI does. So either a CT myelogram or an MRI are really essential to make a determination about the need for surgery. So when to see a spine surgeon? If you have red flags, you should obviously go to the ER or talk to your primary doctor, and they should order both a stat MRI and a surgical evaluation. In the absence of red flags, try outpatient PT, wait it out for 6 weeks, and if you're no better, get an MRI and see a spine surgeon simultaneously. So what is the outcome of these evaluations? Well, it turns out that there are surgical options for some patients with neck and back and nerve pain when the non-operative options fail. Not everyone, however, would be well served with surgery. In fact, most people probably should not have neck or back surgery, just because of how the nature of the spine is and how imperfect surgery's ability is to help wear and tear. You have to have a very compelling reason to undergo neck or back surgery to give good success. Also, many patients are asked to modify risk factors. We know a lot more about the spine and the overall ability to benefit from surgery than we did a decade ago. And we now know these risk factors that really are predictive of complications, of dissatisfying outcomes, recurrent problems. And so some patients are asked to modify these risk factors. So what are the surgical options? So in broad terms, there are two basic operations that we do. We cannot cure a disc. We cannot turn back time and make the spine normal. And there really isn't a great replacement option for discs and joints that wear out. There's one exception in the cervical spine, but every other part of the spine and also the joints in the back of the spine don't really have a way to rejuvenate or replace joints. So our toolbox is really limited to two broad categories, one of which is called a decompression. So a decompression is for nerve pain. It's for that sciatic pain that goes down your leg or nerve pain that radiates down your arm. It's for the pinched nerve. It does not help pain in the neck and the back itself, because with a decompression, all we're doing is creating room for that nerve. And for someone who has predominantly a nerve problem, it's a very effective and satisfying outcome. In fact, it's one of the best surgeries that we do in medicine. It offers upwards of a 90% success rate at relieving nerve pain. And nerve pain is one of the most problematic pains there is. And so it's an operation that involves taking out what doesn't belong, namely an excessive joint, perhaps, or a herniated disc that migrated where it normally belongs and now is pinching a nerve. And it takes that pathology off of the nerve while keeping intact the normal disc or the normal joint. So we basically kind of clean out the space, but we don't cure the arthritis. In other words, the nerve pain will get better, the neck and the back pain won't. It's also important to know that numbness and tingling and weakness, those are signs of nerve damage. They improve about 50% of the time with these surgeries. The main goal of surgery here is to help the nerve pain and prevent more numbness and weakness from setting in. We don't have control over the nerve. We take the pressure off of the nerve externally, but with surgery, we cannot repair the nerve internally. The human body has to repair it and oftentimes doesn't repair it completely. So this illustration is really showing a decompression, taking out an offending bone spur and an overgrown joint. And we liberate the spine from that, and that helps the nerve pain, but does not help the back or the neck pain. There is an option for neck and back pain, the surgical option, for, again, failure of non-operative management. And you don't want to do this operation unless you've had 3 months of non-operative management, because as we discussed, non-operative management oftentimes works. And it's specifically indicated for a select group of diagnoses, not a wear and tear problem. Most people, it turns out, have diffuse wear and tear, and they're not a candidate for this surgery because this surgery is inherently imperfect. It's not a cure for diffuse wear and tear. It's more of a treatment for a focal mechanical problem. So these terms called spondylolisthesis, meaning when one vertebra is kind of sliding forward with respect to the other, almost like a staircase instead of a column, or a condition called flat back syndrome, where the discs are kind of bone on bone and the curvature of the spine is not healthy, or scoliosis, where the spine, rather than being straight up, when you look at the spine from the front, has a curve like a C or an S, or if you have one very focally bad disc and the other discs are pretty normal. Those are really the 4 general reasons why a fusion is a good option. So what a fusion basically is doing is it is artificial. We are eliminating that painful joint's ability to move. We are fusing or uniting the vertebra above and below that joint so that they don't move again, because we lack in our toolbox of spine surgery an artificial joint to rejuvenate it or turn back time. So we're sort of welding together using biology, using screws and bone graft to stop the movement of that joint. And for the well-selected patient, there's a good, high chance of helping their pain. But it's important to know that it will not cure neck and back pain, because it's going to only treat the neck and back pain that come from that joint or joints that we fuse. There's going to be arthritis elsewhere, and so it's important to be realistic here. It's also important when you have a fusion to know that the success rate here isn't quite as good as the decompression surgery at helping the neck and back pain. It is about 50 to 70%, depending on the diagnosis and the research study you're looking at, meaning that a substantial minority of people with these surgeries will have lingering pain. It underscores the need to try everything else before doing this. It also requires a little bit more stringent criteria for selecting a patient who would stand to benefit from this, meaning that if you're going to have metal put into your body, your bones have to be strong enough to hold the metal. If you have osteoporosis, your bone density isn't as high, you should avoid these surgeries unless there's an absolute need, like an unstable fracture, for example. Nicotine use, we'll talk about that in a moment, is a risk factor for poor outcomes here. And then when your BMI or body mass index is more than 40, we call that in the morbid obesity range rather than the obesity range. When it crosses that threshold to 40, then this surgery really should be avoided, because we know from our research that the outcomes are not as good. So it is a very reasonable option of last resort. It can help many people. It cures no one, and a minority of people don't get help. The other downsides of this is it's not physiologic. It won't make your spine normal, and so we're trying to make the bones heal, and there's a risk that they won't heal. That's called pseudarthrosis. There's about a 5 or 10% chance of a non-union, where there's a failure of biology to work in our favor to heal the joints. Also, because we're fusing one area, the disc above and below could wear out. The neighboring disc that now has to take the load to do the movement that the fusion is no longer doing, that neighboring disc could wear out. It turns out that risk is quite significant. It's about 20 to 40% per decade. So this is a very reasonable option for a select group of folks who've tried everything else. And in that patient with mechanical back pain, it can be a life-changing operation for the better. But most people should avoid these unless if you have, for example, diffuse wear and tear. So you want to have a surgeon who can very thoroughly and honestly evaluate your condition. You definitely, most people should avoid these surgeries, but for the select patient, it is a good option. And so what we do here is we put the screws and rods in to hold the spine still to give a head start for the bone graft to heal. We use different kinds of bone grafts, some from your body, some from cadaver bone or donor bone, and we use that to sort of create a biologic healing of vertebra to vertebra. But that takes about a year or two. So the screws and rods kind of hold the spine still while that healing takes place. So the question becomes, since there's no real cure, there's no perfect option for this, what can be done? We have 25 discs and 50 joints, so there's 75 moving parts in our spine. What can be done? And I think, unfortunately, in healthcare, this is sometimes forgotten because we're so busy with the details, but we forget the big picture. And it turns out that back pain and neck pain, not always, but very commonly, are the tip of an iceberg when it comes to risk factors. And these risk factors everyone knows about, but unfortunately, a lot of doctors even don't really have the awareness of how we can sort of change some things about our lives to make even our necks and backs feel better. So these are sometimes dissatisfying to discuss. That's why sometimes doctors don't bring it up, and they're so common, but they're highly important. They are preventable and treatable causes of pain. So the disc is, of course, the cause of the pain, but what caused the disc to wear out? So these underlying things are essential to know about so that you can be informed and empowered to lead the best life that you can. So it turns out that even surgeries, a lot of times there's a perception that surgery is the cure, and it certainly can be an effective treatment, but it itself is sometimes just a Band-Aid if there's these risk factors that continue. Now, it's important to know from research that these risk factors are very powerful. So when we look at a term called relative risk, that means that the number, not percentage increase, but a multiplication increase. And we know that nicotine use, current nicotine use and obesity, meaning your BMI more than 30, has a significantly increased risk of developing neck and back problems, several times, so 4 to 6 times more likely. Turns out depression also is associated with this. Depression, of course, doesn't cause the disc to wear and tear, but of course, if you're suffering, then you're more susceptible to that pain affecting your life. So it goes to show how complicated and big picture we have to look at when in terms of managing neck and back pain in the long term. And these are also important to know. Not only do they tend to cause these very problems, but they're also risk factors sometimes for poor outcomes because they lead to more discs wearing out later on. So these basic facts, sadly, are often neglected, but they must be told. And so one risk factor is nicotine. Why is that? Well, it's not the smoke. So nicotine itself is a drug, and it has an effect, we think, related to the spine, related to decreased blood flow. So blood is, of course, necessary to keep all organs nourished. The disc naturally has very limited blood flow. If you cut your skin bleeds. A disc looks like crab meat. It's a pearly white, relatively avascular structure. It barely has enough blood, even in an ideal circumstance, to function. That's probably why discs tend to also wear out too. The way we're all built, there's not a lot of blood flowing to them. But what nicotine does is it diminishes blood flow. Nicotine is a vasoconstrictor, so it diminishes the nutrition that your body needs to keep that disc healthy. So oxygen, protein, minerals are delivered less. And so it turns out that the people who smoke, but also vape, or even chew tobacco, or even use a nicotine patch are about 4 to 6 times more likely to have neck and back problems. Obesity, it's a mechanical phenomenon of stress on the discs. And then when you get the disc disease, the existing disc disease, of course, has to then bear more load, and then that can exacerbate the pain. So it can cause the disc disease, and they can exacerbate the pain. And I ask folks to focus on these because these are things that one can control. Other things one can control. You know, if you have a history of psychiatric illness, that's kind of out of your control. If you've had a history of hard work, you know, in construction, that's not in your control. You can't change that. You can't change that you're aging. You can't change your genes. So don't focus on the past, and certainly don't blame yourself. But look at what you can do in your toolbox too, as a patient who's empowered to lead the best life that you can. So these are basically slides looking at a rat in research on the effects of nicotine. You can see the bone and the bottom is less colorful, and basically the nicotine causes the bones to deteriorate and the discs to deteriorate, and that's why smokers unfortunately suffer without their knowledge of high rate of neck and back pain. Even vaping is not safe, and a lot of young people are vaping nowadays. Obesity, it's a mechanical phenomenon. It's bearing more weight, but also the body weight tends to push your spine forward. And think about leverage. If you're having to carry 50 pounds right on your chest versus in front of you, the further away you're having to carry that weight, the more torque there is on your spine. And so it's this sort of mechanical force times distance that's making that more severe. So obesity is not just years of life lost, it's quality of life lost. It's important to know that. So any form of nicotine and any degree of obesity, which of course is increased the more severe it is, are risk factors that are modifiable for disc disease. So when it comes to the discussion of this, we want all folks who are using nicotine to try to quit. It is hard to quit. It will take an average person 3 to 5 times to try and fail before they get there. But people in general can quit. It is hard, and you can certainly use a patch as a means, but only as a means to an end of completely quitting nicotine, because the patch will cause the discs to wear out just like smoking will. So nicotine cessation won't turn back time. It won't make your discs normal, but it can lessen the severity of pain you currently have, and equally important, prevent more problems in the future. Now, if you're a smoker, you can have the decompression only surgeries. We can do that surgery, the clean out surgery for nerve pain, in the setting of nicotine with a pretty decent success rate. There is a higher rate of more wear and tear in the future, but that current problem, that hernia disc, that overgrown joint, you'll probably have a good outcome if you have that surgery, the decompression only, which again is for nerve pain only, not neck and back pain. On the other hand, the fusion surgeries that we do, the surgeries for neck and back pain, are impossible to create a good outcome in the setting of nicotine. The risk-benefit ratio is unfavorable, meaning that the chances of you getting better with that surgery are like 20 or 30%. The chances of you being hurt by that surgery are more than 50%. So it is hazardous to do an elective fusion for chronic neck and back pain if you're using nicotine, because the bone healing that surgery requires, that too is impaired by nicotine. So nicotine both causes the discs to wear out, but the bony fusion, that biologic welding of the spine together that we're trying to achieve. Remember, we don't make that happen with surgery. We put bone graft and screws and rods in the spine, but we need biology to actually work in our favor to heal the bone graft. And that healing requires blood, and nicotine impairs blood flow to the spine. So elective fusion surgery, we require, and almost every healthcare institution that values patient safety requires folks to quit all nicotine prior to the surgery, because it's essential for their long-term and even short-term outcomes. So there's resources. We have at Geisinger what are called health coaches, which are nurses that you can meet up as much as you like to make goals to quitting. There's also medications you can talk to your primary doctor about, and support groups. And as I mentioned, a nicotine patch is an okay bridge, but it should not be the last end result, because it will cause problems. Better for your lungs, but not better for your spine. Weight management. So anyone whose BMI is more than 30, and that's very common. A very large percentage of our population has a BMI in that group. So this is certainly something that you're not at fault for and you're not alone for. But we just know from data that this is a risk factor for the spine wearing out. And so if you have a BMI of 30 to 40, you can safely undergo these surgeries, both the decompression and the fusion, because in that range, it's more of a risk factor for long-term problems. It's not going to interfere with your ability to benefit in the short term from a decompression or a fusion, because obesity does not affect the fusion or the union of the bones, whereas nicotine does. However, if the BMI is more than 40, then once again, the risk-benefit ratio is just not favorable. At that point in time, there's just a mechanical disadvantage of the body weight interfering with the surgery's ability to help a patient. There's a deeper incision, and so infections can set in. Also, where we operate, the screws and rods, for example, can get loose if there's more weight than they're designed to carry. And so a BMI of more than 40, unless there's an emergency, like someone has a fracture that they're going to get paralyzed by, we have to ask that patient to quit the nicotine or lower their BMI before we can do that surgery safely. And there are resources now more than ever for this. Everyone, I think, for example, knows about a dietitian. We have a lot of dietitians at Geisinger. We have bariatric surgeons, but in particular, the last 2 years, there's been these new medications that have been shown to be very, very effective. It's hard to lose weight with exercise when you're in pain, but these medications that you inject in your arm once a week are as effective, if not more effective, sometimes than bariatric surgery without the risks of that. So there's a clinic here at Geisinger called the Weight Management Clinic, also known as GI Nutrition. You can be referred to by anyone, by your nurse practitioner, by the spine surgeon, by your primary doctor, by the pain management doctor to help you reach that goal that we want. So it turns out that prevention and risk factor modification are key. We can do surgery, and we oftentimes help people with surgery, but we have limits about what we can achieve. And sadly, even many doctors are unaware of, like primary doctors are unaware of telling patients about the effects of nicotine. And these industries, these tobacco and food industries are incentivized for profit, not for health, sadly. And so they don't inform the public about these basic things. Everyone knows about lung cancer, but how many people, how many even doctors know that nicotine is bad for the spine? It is unfortunately a reality that is not shared enough. And these things are more powerful, and they're actually safer than treatment. Certainly treatment is frequently safe. The chances that, let's say, surgery will paralyze you is 1 in 1,000, but they are invasive and there are downsides to surgery. So prevention is key, and we can treat things, but try to prevent even if you do need treatment. So it's important to know when talking about these things that these risk factors are not your fault. These are the results of habits that are picked up early in life without any awareness of really the effects. And so you shouldn't feel embarrassed, you shouldn't joke. This is just a medical condition like anything else. It's not something you are. It's a diagnosis you have and nothing more than that. But if we ignore that, if we ignore these basic facts, more problems are going to arise. It is expected that if you have surgery or not, if you have these uncontrolled risk factors, that in 5 or 10, 15 years, or maybe even sooner than that, there will be more problems. And so again, 75 moving parts in the spine. A surgeon can't cure all of them. And we want you to take control of your life to have the best possible outcome. And so because there's no cure for disc disease, and because we know that obesity and nicotine cause the very problems that we're all struggling against, we want everyone to control what we can control to maximize their quality of life. And so again, it's risk factor modification. That is from the beginning to end of this. It's a lifelong objective. And then in terms of the basics, we start with physical therapy, and then as an intermediate measure, pain management injections, and then as a last resort, surgery is indicated for a select group of folks. And in well-selected cases, people can have upwards of a 90% success rate, but in poorly selected cases, the success rate is as low as 20%. So you want to have someone that can really evaluate you and talk to you honestly about your pros and your cons and your success rate when undergoing spine surgery. So I'm going to move this over to the audience now. If you guys have any questions, I'm going to move the screen over here, and you can log in and either speak or write in the Q&A some questions. I'm going to pull that screen up, and we can see if we have any right now. You just bear with me a moment while I pull up our other screen here. Okay, let's take a look here. So we have one here, Teresa. So she was at CMC for 6 days with back pain, and there's non-cancerous lesions in the mid and upper back. So that question, I will tell you, Teresa, is a very specific one to your condition, and without knowing your medical history, unfortunately, I can't comment upon that. But what I would do is ask your primary doctor if there's any, have them review your results of that. And if there's any concern, you can be referred, to a spine surgeon. Most of the time, when you have an abnormal MRI and you're in the hospital, they will already have consulted a spine surgeon. That is the default option. So maybe I would suggest meet up with your primary doctor and review the records, review what the spine surgeon said, and if for some reason you were not seen by a spine surgeon, then certainly put a referral out. So I'll dismiss that. That's a very good question. And I think communication is very important when it comes to your health. And it's good that nowadays we all have access to our medical records where you can go on My Geisinger and look at your results. You can look at your doctor's notes. You can look at your MRI results and share them and communicate. We want you to be empowered and be aware. So speak up to your doctors and have them help sort that out. Is there an ideal age range for surgery? That's a very good question. So it turns out that the decompression surgery can be done in any patient at any age. The surgery that does not rely upon bone grafting, a 95-year-old could have that surgery done, assuming that their heart and lungs, can withstand a 2-hour anesthesia session. If it's, however, requiring fusion, in general, around the age of 75, we all get osteoporosis. Osteoporosis is softening of the bones related to hormonal changes as we age. Usually around the age of 75, unless there's a really compelling reason, we avoid those fusion surgeries, meaning that for someone in that age group, 75 and above, we can do a decompression. In fact, 75 and above is one of the most common reasons people get a lumbar laminectomy, which is a decompression of the joints in the back. So a decompression is good for anyone in any age group, but a fusion, meaning for the pain in the middle of the back or the middle of the neck, probably should be done sooner than age 75. That said, there's no such thing as a preventative spine surgery. So if you have mild or moderate pain, but it isn't really affecting your quality of life, you should not have surgery. Surgery is by its nature imperfect. We can cure arthritis, but then we create arthritis at the neighboring disc. So don't do surgery out of fear necessarily. If your current quality of life isn't great, well then of course, pursue surgery if there is a surgical option. But the idea of, well, my pain is mild now because I'm 60 and I don't want to have severe pain when I'm 70, that would not be a good reason, because it turns out that the spine sort of stabilizes itself with aging. We create bone spurs, we stiffen as we age. That's actually a natural healing process, almost like a fusion, almost like what we do with spine surgery. The human body does that as we age. We sort of stiffen. That's a protective thing. So the idea that you need surgery because you have some pain, that would be too aggressive. So basically, the answer to your question is do surgery if you're in severe pain, and you can do a fusion if you're about 75 or younger and you're not, smoking, and your bones are strong enough, and you have a mechanical reason. But anyone in any age group can get a decompression. And certainly, see a spine surgeon to talk about that, because it's a very complex. But the spine is very complicated, and there's many surgical options, and frequently patients have a choice of a couple. It's not just like you have to have this one kind of surgery. You could have a bigger surgery to help your neck and your nerve pain, or a smaller surgery just to help your nerve pain. So posture, that's a good question. Definitely see a physical therapist. Some posture issues are not within your control. For example, if you have osteoporosis and your bones have what are called compression fractures, where your spine is sort of, over many years gone more forward and forward and forward, that is not really necessarily in your control. Anyone who is 65 or older should talk to their primary doctor about osteoporosis screening. Osteoporosis causes compression fractures. So if you have If you're in that older age group, you want to be screened for osteoporosis, because those things are not correctable, meaning that once you have a fracture in your back, it's going to heal, but your posture will never be normal. So get screened for osteoporosis. If you don't have a fracture, however, in general, the posture is able to be corrected with physical therapy. So if it's not a fixed deformity in your bone, but more like your muscles are weakened, which is also just part of aging, then go and see a physical therapist to improve your posture. Good question about how long to do PT. So again, in the absence of red flags, if you have complete loss of urinary and bowel control, you can't move your foot up in the air against gravity, you should go to the ER or have your PCP refer you, for a stat MRI. But if you're in that group where like 95% of us with neck and back pain don't have an emergency, then do physical therapy for 4 to 6 weeks. And then if there's no improvement, then your primary doctor will order an MRI and have you see a spine surgeon. Any other questions that you guys have?
Dr. Strom, could you talk a little bit about what recovery looks like after surgery? I'm sure it's different for everyone, but curious if there are any general things people could expect.
Absolutely. So it is quite varied. We do a gamut of types of surgery because everyone's spine is different and has varied needs. Some of our operations are as little as 1 hour long, and you go home the same day with an inch-long incision. Those are like the small disc surgeries, for example. And that individual will probably have a few weeks of muscle pain, and then pretty much a month or month and a half later, they're doing normal things. So that first month and a half, they'll just want to take it easy, like they can do chores, they can go on walks, they can drive. They're not going to want to do heavy lifting. They're not going to want to do any, straining on the job, but they could go back to an office job within a week or two of surgery. So those smaller decompression surgeries, whereas the reconstructions, these folks, generally speaking, have to spend the night in the hospital because there's just a larger incision, there's more work to be done, and the recovery is longer. And so instead of 1 month of muscle pain, it's about 3 months of muscle pain. Instead of a same-day discharge, usually it's an overnight stay, sometimes the next day, for the more 1 or 2 levels. For people that have scoliosis, major deformities of their spine where they need to have a majority of their lumbar spine and part of their thoracic spine corrected with 1 foot long rods, with these major deformities, that can be a 6-month recovery. But in the end, those patients with deformities, even though they have the longest recovery, tend to actually have excellent outcomes. About 80% of them get significant improvement in their pain levels and their disability levels because they are suffering from a malaligned spine, which is of course highly debilitating if you can't even physically straighten your spine out, and we surgically correct that with screws and rods. So it varies from as little as 1 month to 6-month recovery. And by recovery, we mean not being in bed. We want you up and walking. We want you to, do the light thing. It's important, to avoid complications of back surgery. The complications are not what you might think. Being paralyzed from surgery, which is a fear people generally have, and that's an understandable fear, that is nearly impossible. It is about a 1 in 1,000 chance, so it can happen. But the typical complications are more medical complications, things like bacteria entering your incision, or getting blood clots in your legs because you're not walking as well, or getting pneumonia. So those sort of complications are preventable by being active. So we want you walking, and doing some physical therapy. There can be a physical therapist after surgery that comes into your home. So if you're living alone, you don't have to recover at home alone. That is oftentimes not even safe. If you're older, if you're younger, then you can. So Geisinger can set up a physical therapist to come into your home and help you to shower, to eat, for example, to get those basic activities of daily living. There's also the option of rehab if you have very major surgery, or if at baseline you just have more needs. If you're having difficulty walking at baseline, harder time walking into the hospital, maybe walking out of the hospital going home may not be the safest thing. Maybe going to a rehab institute, which is like a hospital, but it's more of a residential setting for a week to get some physical therapy, build up your strength, and then go home. So all those things are possible, and it's really whatever the needs of the patient are. Good question. Daily exercise, I'd recommend probably one of the best things to do is long walking 20 or 30 minutes a day. essentially whatever your body feels. We all have different endurance levels, and if you have severe pain, you want to stop. You don't want to push yourself into the severe category of distress. Pushing yourself through mild pain is good, but into that severe category, it won't make your disc worse typically, but it will torment you, and you don't want to push yourself too hard. So basically, stop when you sort of feel sort of enough, and in general 20 or 30 minutes. And then physical therapy, really, they're the experts at exercises. As a neurosurgeon, we're of course performing surgery, but very little about the physical strength building do we actually have really training even to direct. So I would suggest talk to a physical therapist about exercises, and it's important to know, like everything in life, some exercises will work well for one particular patient and not so well for another. So you want to learn those exercises that you feel good about, because it's your body at the end of the day, and do not let a physical therapist or anyone push you in ways that will cause tremendous amounts of pain. Know your limits, basically. But essentially, the best things for the back are things that pull your center of gravity backwards. Remember, with physical therapy and all the sort of non-operative management, we're wanting to let the spine heal. Well, if the spine's bearing weight, it's harder for it to heal. So by turning your center of gravity backwards, improving your posture, being more upright, you can unload the discs that are painful and promote more natural healing. So walking, it turns out, is low impact, and you're forced to stand upright when you walk. It's hard to actually walk when you're kind of bent forward. So that's why that's a good exercise. But I would talk to a physical therapist about specific exercises. That's a good question about sleeping. A lot of folks find that sleeping is uncomfortable. It's a very similar, honestly, answer to the other question that I answered. It's really up to your body to tell you what posture is the most comfortable. There's not really a medical study that says this particular pillow or sleeping modality works better than others. Basically, try everything that is possible. Try sleeping in different positions, try using different pillows or mattresses, and the one that works best for you is the best for you. To say that, as a physician, for me to promote a particular product without any type of evidence, medical evidence, it would just not be valid. So we're all different. Sleep in the way that helps you. Sure, yeah, I'd be happy to answer this question was about sleeping posture. So this next question is about having scoliosis and osteoporosis. And Helen brings up a good point that when you have that combination, that can be difficult to manage, because surgery is much higher risk, to correct scoliosis when you have osteoporosis. So I think bike riding is very reasonable. Some people swear by swimming. I think all these aerobic exercises are good. You want to avoid things like weightlifting or anything where you're really bent over too far. I guess one sort of worry about bike riding is that you are kind of bent over a lot. So maybe focus on your posture and make sure those handles are more upright so you're not bent over as much, or use one of those kind of reclining bikes like in a gym, for example. Essentially, when you have a problem in the spine, the more part of your day where your head is on your shoulders and your shoulders are on your hips, the better. That kind of forward alignment is what sort of exacerbates disc disease, and also exacerbates pain too in general. But again, if biking feels good to you, I don't think you're going to make your scoliosis worse, because we're all different. And you, at the end of the day, are the expert of your body. No doctor knows your body the way you do. So do what feels good to your back. Kudos to you for staying healthy with that. Any other questions? It was a pleasure talking to you all today. I hope this was informative in terms of giving you a blueprint. Of course, every human body is different, and you want to see a doctor about this. You don't want to self-diagnose. See your primary doctor, have them review your symptoms. If you haven't done so already, initiate non-operative care. And then if that doesn't work, come and see a spine surgeon, or you can see a pain management doctor. Both, they're sort of like the non-surgical equivalent of me. A pain management specialist is kind of like a cardiologist, whereas a heart surgeon is kind of like myself. And so you can see either of us, and if either of us feel that you would be better served by the other, we will be the first to say that. We do not bring patients into surgery unless it's truly necessary, and we give all options on the table, and they do the same thing. They will not put you through injections if you need an operation. So you can either see a pain management doctor or a surgeon if the non-operative things failed. And any questions at all, you can always schedule a visit with me or any of my colleagues. We have neurosurgeons both in the Scranton area and in the Wilkes-Barre area. And I think open communication is great, and we're very fortunate to live in the age we do, where this is possible, where we can talk. I think a group of 100 people joined today, and so the more information you have, the better. There's not such thing as too much information when it comes to the human body and your health. All the best to you guys.
Thank you very much, Dr. Strom, and thank you to everyone who could join us today. We agree. We hope you found this program informative and helpful, and please enjoy the rest of your day. Thank you so much.